I am Dr. Sharian Brown with Fits on the Go, and I am here with Dr. Neil Stone. Dr. Stone, welcome to Fits on the Go.
It's my pleasure to be here.
Dr. Stone, I know that you've been participating in some great sessions here, and given that you're first author on the 2013 ACC/AHA guidelines for blood cholesterol management, we thought that there'd be some great questions that you could help us with. The first one would be, what are your thoughts on comparing the similarities and differences between those guidelines and the most recent USPTF recommendations for statin initiation?
Yes, well, the recent new guidelines for statin initiation are very interesting because they essentially endorse what the 2013 ACC/AHA said. They endorse the idea of certain statin benefit groups. For example, they make a commentary about those 190 or more who have familial hypercholesterolemia. They endorse the idea that you can define a lower risk primary prevention group, and they say that instead of just using the ACC/AHA risk assessment of 7.5%, that they would use either 7.5% with a C recommendation or 10% as a B recommendation, but also include people with one or more risk factors, including problems with blood pressure, blood sugar, or cholesterol. The differences are small. We were very happy because one of the major advances in the ACC/AHA 2013 guideline was the concept there'd be shared decision making before a statin was given. 7.5% wasn't an automatic a statin prescription. It just initiated the discussion. So we think that this is very consistent with that, and that the trend toward guidelines now has been to include shared decision making as we initially represented. And although there's been some concern about accuracy of the ACC/AHA risk estimation, there's concern about all elements of risk estimation. The point is shared decision making is what allows you not to work with a fixed number, but to ask yourself, am I now in the range where considering a statin would make sense? And in that sense, I think these guidelines are very similar, and I think these guidelines should be helpful to clinicians.
So, Dr. Stone, that was really great and will be very beneficial in our care of patients. Now, the next question is, what do you think about implementation of genomics in the clinic?
I think implementation of genomics is just an extension really of family history. And of course, the great advantage is that in so many cases, we really don't have good family history data. So genomics can be a real plus. One of the problems with telling people results of genomics is that sometimes they feel like the genomics is their destiny. They really don't have any hope for how they'll do. And the ability to say that lifestyle can make a big difference, I think, is a very positive message and a terrific way to endorse the value of a healthy lifestyle. 90 years ago, Elliot Joslin, the founder of the Joslin Clinic that's taken care of diabetics so well for so many years, said, genetics loads the gun, but environment pulls the trigger. And that's something I use with patients, and I think something clinicians can use to help them understand that understanding their family history really arms them. I always say forewarned is forearmed. It allows you to, one, decide how you can make better lifestyle changes, to think about what drug therapy might be beneficial to you based on your individual characteristics, and then to think about how family screening could influence the lifestyle of your family. So at the very end, this could have a positive influence on our nation's health.
Fantastic. And there was just a study presented that showed that regardless of the genetic risk, lifestyle indeed can make a big difference. What are your thoughts on that one? Well,
I've been a big fan of endorsing lifestyle my entire career in medicine. I was chair of the Nutrition Committee of the American Heart Association more than 20 years ago. And one of the points we used to make was better off the plate than out of the bottle. That too often patients got their fortification through all kinds of pills and capsules when in fact they should be endorsing a healthy lifestyle. We've known for years what the components of a healthy diet. They may vary from one diet to another, but lots of fruits and vegetables, lean protein, good oils, like extra virgin olive oil, canola oil, nuts, seeds. All of these can be elements of a healthy diet that patients can endorse.
And do you think that at some point genomics might be incorporated into future guidelines?
Well, I think that's a challenge for guideline writers, but it certainly could allow us to try to understand how we tease out those in the low risk group especially. You know, if you look at where coronary disease occurs, it doesn't occur just in the highest risk. A lot of the burden of coronary disease occurs in those with risk less than 10%. And if genomics can help us tease out who's actually at higher risk and we need to devote attention to, and perhaps who we could just say lifestyle alone, that would be a great plus altogether.
Wonderful. Thank you so much, Dr. Stone. It's been a real pleasure.
Thank you.
Join us for more videos at youtube.com/fitsonthego.